Hello, everyone, and welcome to the Toronto General and Western Hospital Foundation COVID Q&A. We hope you're staying safe and taking care of each other during the pandemic. I'm Christian Cote, host of the UHN podcast, Behind the Breakthrough. We're glad you could join us and grateful to you, our family of supporters who've been so generous throughout this challenging time. So a big thank you on behalf of the foundation and all of UHN. This episode, we're talking about the vaccine, the virus, and the potential now for a third wave. Plus, we'll be taking your questions later in the program. So today with us, we're so pleased to have one of our regulars on the broadcast, Dr. Alon Vaisman, UHN infection control physician. Welcome, Dr. Vaisman.
Thanks for having me.
So let's start off with some good news. The case counts, weekly and daily, have been going downwards. So obviously the lockdown measures the last several weeks are working. I'm curious, from a public health standpoint, would you keep going? Would you say, let's get to zero case counts?
I think getting to zero will be very, very challenging, but at least going a little bit longer with the current stay-at-home orders and some of the restrictions, I think is generally a good idea because of the two important variables to consider. One is that the variants of concern are rising, and the variants are strains of the virus that you're more likely to pick up if exposed. And secondly, our vaccination numbers are going up. So two variables, we have a little bit of time now to bridge to a time where we have at least more people vaccinated. Unfortunately, because of the delays that occurred in January and February due to supply issues, that timeline is a little bit delayed. But hopefully we'll be able to get vaccinations into people a little more now in the end of February, beginning of March. And if we can keep things a little bit restricted until that time for a little while longer, then at least we can have a situation when things open up, we'll have more people immunized against the virus. This will hopefully prevent a possible third wave that may become as a result of these variants being more transmissible and more common.
And I want to dig deep into the variants and the potential for a third wave, but big picture, this balancing of economic reopening and case counts under control. Ontarians have made huge sacrifices for close to a year now, right? And it just seems to be this continuing cycle of rising case counts, lockdown, get the spread of the case counts under control, and that's followed by easing restriction, and then we seem to cases start rising again. So this roller coaster is now very exhausting for many people. Many of us are depleted. Is there a public health way or a recommendation for doing this without sort of this yo-yo, reopening, lockdown, reopening, lockdown? What would you say to that?
Yeah, that's a very important observation. And of course, Ontarians and everyone is very tired of having to go through the lockdowns. And of course, there are very, very significant mental health and economic consequences that people are suffering. But there's a very key difference when you look at the situation now compared to the first wave in the spring of 2020. When we removed the lockdown restrictions in the spring of 2020, that was essentially a bridge to nowhere. There was no viable vaccine candidate at that time. There's no available vaccine, I should say, at that time. There was no herd immunity. There was no chance at that time that we weren't going to see more cases. That was almost an inevitability. But now it's totally different. Instead of a bridge to nowhere, we have a bridge to vaccination. So this roller coaster sensation that Ontarians and Canadians are having in general about opening and closing is certainly stressful, but this is a very different time. If we are able to bridge this lockdown over to the time where we are able to vaccinate enough people, then hopefully we can prevent this cycle from starting all over again. And the government discusses this as well with breaks and going back and forth. And I think if we just have a smooth transition from easing restrictions to having vaccine numbers elevated, we will avoid that yo-yo, that roller coaster ride. And hopefully that'll be the case. Hopefully, as I said, between February and March, we're able to vaccinate more people. We will avoid that cycle altogether.
Okay, fair enough. So as part of reopening, we keep hearing that if you want to ease restrictions, then there's got to be more aggressive testing, rapid testing, contact tracing, etc. What's your take then on how we're doing on this score as we are set to reopen again in Toronto and Peel, and many other areas are already open?
Yeah, the one front on that area, so testing capacity has increased massively the last few months, and is certainly available if made available to people to get access to. But the main concern is the contact tracing. in the city of Toronto since September, we're still not able to do effective contact tracing. So another argument to be made about loosening restrictions a little bit slower is to allow for the city of Toronto, for the public health officials, to do better contact tracing. With the variants on the rise, the contact tracing will become that much more helpful, that much more powerful. So that's where the concern is, where with lifting the restrictions too early, is that key component, as you identified, being an important measure of keeping cases down, is not going to have the capacity to do that. If you're able to bring the cases down to the point where contact tracing can be restarted and effectively performed for the vast majority of cases, then at least we'll have the tools in place to deal with the resurgence of cases if that happens. But if the cases remain very high, that unfortunately won't be an option in the near future.
Okay. What about schools? Because all of Ontario's schools are now back in session in terms of in-class attendance. But there's a cautionary tale that we were talking about earlier about, or before the broadcast, about Montreal last week, where we've seen close to a doubling of school outbreaks. What do we need to do here in Toronto and Ontario to keep schools open and safe?
So there is a very important principle that has been recognized across the world about school openings, which is that cases in schools can be fed by the community, and cases in the community can be fed by school outbreaks. So there's a back and forth relationship. I think most people in Ontario and in Canada would recognize that opening schools is one of our top priorities because of the health of children and the education of children being a very important top priority. And so with that opening, as we saw last week in Ontario, that makes the argument even more to slow down the opening of the rest of the economy. If we value schools as one of the important things we want to keep open for the sake of parents, for the sake of children, then the way we prevent outbreaks in schools, the way we prevent schools from becoming a source of infection, is by minimizing the community acquisition and the community prevalence of disease. And the way we do that is maintaining some of these restrictions to help prevent that. So certainly as schools open up, we will start to see a slight bump in cases. That probably will happen because of more contact. But we can try to keep that to a minimum if we at least restrict other forms of interactions of people.
Okay, we are hearing that a lot. Very nuanced messaging that is so critical, hourly, if not day to day. Okay, so this third wave lurking on the horizon, apparently driven by the variant strains. Some, and I've heard you even say this last week, the predominant strain could be one of these variant strains could be the dominant strain in Ontario within a couple of weeks. And the case counts apparently are going to be ugly. I've heard that term used to characterize what is on the horizon. So is there any way around this? Like, can we avoid this?
Yeah, as you mentioned, the modeling from the science table in Ontario shows that the strains of concern, particularly the one that came from the UK that is thought to be more transmissible, is likely to be the predominant strain by mid-March. Whether or not that will result in another wave of cases, in another large volume of people getting the disease and dying from the disease, being admitted to hospital with the disease, will again depend on what kind of restrictions we have on people's movements. Even if the dominant strain becomes the more transmissible strain, it doesn't necessarily have to result in a lot of cases if we can minimize transmission, if we can keep things in place a little bit longer. Furthermore, if vaccination ramps up, if we get more people vaccinated, especially the elderly who are living now in the community, that will protect the most vulnerable people. So even if there's a transmissible strain, the most vulnerable people will be protected using the vaccine. Another important observation that we see across the world sees, is the observation from the UK, where these strains were the predominant strain and currently are, and yet they were able to get on top of it and bring the case numbers down. That is an important observation because they were using the same techniques they've been using since the beginning of the pandemic. The same things we've been talking about over and over again: hand hygiene, masking, keeping distance, restricting people, minimizing congregation, all those things work against the variant of concern. So those are all reassuring things for people to understand that it's not inevitable that we have to see a third wave, even if the variants become the predominant strain in Ontario.
I see. Okay. I'm curious though, what is it that makes them so contagious? I've heard up to a percentage of like 70% more contagious.
Yeah, there's a variety of estimations about how much more transmissible these variants are compared to the usual strains that we see here in Canada or the United States. Part of the explanation as to why the virus is more transmissible may be its ability to enter cells. It may be that it has a stronger ability to attach to the cells, to the respiratory cells, and be able to penetrate and get inside compared to the usual strains. It's important for people to recognize that viruses constantly mutate, and COVID has constantly mutated since the beginning of the pandemic. In fact, the strain living in Ontario in December and January before the other strains came in was not the same that we had even in March, for example. So although the strains are not the same, there are some that will invariably lead to more or less transmission. The ones that will cause more transmission will unfortunately be the ones that predominate. Those are the ones that will survive better and will be able to move from person to person. And that's unfortunately the reality in several countries around the world.
So along the lines of trying to protect ourselves, I'm hearing a lot about, once you leave the house, especially with this threat of the variant spreading, we should be double masked, perhaps triple masked. What's your take on that, and how do you do that?
Yeah, the CDC, the American body that makes recommendations regarding the transmission of infectious diseases, they have suggested that one option is to double mask. Of course, there are other options that they have offered, including making sure that you have a tightly fitting mask, making sure that things are well suited to your face. It has not been adopted yet by Canadian bodies. The federal government and the provincial government and the City of Toronto, for example, none of those bodies have recommended double masking. The evidence regarding that was based on experimental data on mannequins and has not yet been shown in actual real life cases in terms of decreasing transmission between people. That's not to say that it's not effective or not necessary, but as a result, it has not been picked up as a recommendation in Canada. If one chooses to use double masks, the recommendation from the CDC describes one putting on a surgical or procedure mask first, and then adding the cloth mask on top of that. The basic reason is that surgical and procedure masks, these medical masks, they were never designed to be worn on top of another mask. They've only been designed to be worn directly to be in contact with the person's face. And so if a person chooses to wear a cloth mask, it would go on top of that. And that, again, has been recommended by the CDC, but not in Canada.
Okay, that's helpful already, because I have to reverse my practices. I'm hearing in Ontario about 240, maybe 250 cases of variants have been identified so far in Ontario. Do you think that's accurate?
Yeah, I mean, it's a moving target. The variants are constantly rising for sure. In the beginning, in January, what the Public Health Ontario Lab was doing a random sampling of cases, plus looking at high-risk cases like people who came from outside of Canada and looking for the variant. And the estimation initially might have been somewhere around 3%. But now the Public Health Lab is actually testing all positive samples of COVID in Ontario. So we are getting answers about how common it is. Now it's probably closer to 5% or somewhere between 5 and 10%. And we're going to get weekly updates on this from the science table. But there's no reason to believe that their prediction will be wrong and that we will have this variant being the dominant strain by mid-March. Again, because a strain is more able to transmit between people, is more able to infect you, it's only a matter of time before that becomes the dominant strain. Even though we've restricted travel or made people test before travel, it's already here and it's already moving through the population. So it's only a matter of time.
And to your mind then, Dr. Vaisman, would there be an ideal R value in terms of R number if that becomes the case, where the variants are the predominant strain?
Well, what has been described by the science table during the last few weeks is getting an R down below 0.7 with the variant being present will be kind of the magic number that they're looking for to at least be able to bring cases down sufficiently to avoid the large peak that we've seen in wave 2. So to avoid the overwhelming of ICUs, of hospitals, of medical facilities, all those kinds of things. So getting down what they have quoted based on their math, based on their modeling, is 0.7 or less, a reproductive number of 0.7 or less.
So obviously this third wave gives tremendous urgency to vaccinating and as many people as possible. It's like this, game of chicken almost, the two of them heading towards each other. What's your sense with the delays in the vaccines that we've had? Has that thrown off our schedule, if you will, in a significant way.
I think that what it has thrown off probably is our ability to open up sooner. If we were now sitting on February 18th today with, a large proportion of our population vaccinated, then there would be a stronger argument to make to open things up sooner. That's probably where the delay is. It just so happened that our peak of COVID cases across Canada was approximately the second week of January in most parts of Canada. And the time it takes for cases to come down is quite slow, as we saw in the first wave as well. And has also coincided with the time that the vaccine delivery had substantially reduced from the most common one being Pfizer, and also with Moderna, both the common vaccines that we're getting in Canada, the two approved ones. So unfortunately, it coincided with a depletion of the stock and not being able to replenish it from outside. And that, unfortunately, in terms of timetable, has delayed our timetable to open up after this wave that we just experienced in January.
But like in the last day or so, we're hearing shipments have resumed. What's your sense then of the timetable of the phases of the groupings of Group A, Group B, Group C? I'm not going to hold you to it, but I know it's reassuring for people to at least hear or understand the time frame in some generalities, I guess. But what's your sense of how that's maybe shifted a bit?
So to give people an understanding based on, let's say, UHN, we were able to vaccinate a significant number of people with dose 1 in January, but not all of UHN employees have received dose 2 yet. So it looks like, based on the current supply that has been promised for Ontario and for Toronto, that if you take UHN, for example, that we'll be able to complete our second doses for most people, for virtually everyone, in the next approximately 2 to 3 weeks. And we'll be able to start vaccinating other sectors of the healthcare population here at UHN over that same period. So it looks as though approximately the next phase will probably be starting early or mid-March. It all depends on how fast you're able to get phase 1. So just to remind everyone, phase 1 included all the people living in long-term care facilities, including their caregivers, as well as people working on front lines in hospital settings. Very fortunately, that goal, the first goal of long-term vaccinating people in long-term care, that has already been completed. So the remainder is to finish vaccination of the healthcare workers. That makes the vaccination of the next step may be done coincidentally with the healthcare workers. Based on the numbers that we are hearing, based on the descriptions from the public health officials, it looks like late February, but probably mid or early March is when that next phase is looking to begin. But yeah, as you said, hard to know.
Okay, so in that phase 2 that may, best case scenario, start early March, who's in that again?
The primary group that they're looking at is, first of all, people who are aged 80 or greater. And after that, it'll include people who are stepping down in terms of age groups. Within that, also that group will be people who are vulnerable or who are immunocompromised, people who are living in the community, essentially. So if you look at the most vulnerable people in the population, the people living in long-term care, those are, of course, predominantly elderly individuals. But there is a sizable number of people who are still elderly and vulnerable who do not live in either long-term care or other congregate settings, such as a retirement home or assisted living facility, for example. So that chunk, that significant number of people who are in the community living on their own with their families, that is the primary goal of the phase 2, is to vaccinate as many of those individuals as possible, including all the people who are have comorbidities, for example. And that's the primary focus.
And so that could be happening as early as, again, not going to hold you to this, but as early as early March.
Yeah, the initiation, we hope perhaps early or mid-March will be the beginnings of that. And as we speak, plans are being made on how that will be best done. So that, seeing as how they live in their homes, you have to find a way to reach them. For example, family physician offices, walk-in clinics, pharmacies, centralized places like hospitals, or centralized places like community centers, for example. Those plans are currently being worked on with local public health units to figure out how best to reach those individuals.
Great, okay. Another thing I just realized or read and did not know until about a week ago, and I think it might be useful for everyone out there to understand, if you could clarify the vaccine's protection, because what I realized, it doesn't stop us from getting COVID. It simply reduces or eliminates the symptoms, correct?
Well, so in the trials that looked at the vaccines, what it showed, for example, if we take the Pfizer or Moderna, about close to 95 or 90 to 95% effective, what it showed is that in the group that received the vaccine, compared to the group that didn't, there was approximately 95% reduction in cases. So only a small proportion of people who were vaccinated compared to the placebo got COVID. So it's a very, very effective vaccine, which practically means that you're not getting COVID. Furthermore, in that group, there were no deaths. So in other words, if you are getting COVID, there's very unlikely to be severe cases based on that data. So the part that's perhaps a little bit less clear is whether you're able to get a mild infection and transmit it. The likely answer is that for the most part, most people will not do that. One indirect piece of evidence that supports the fact that you won't be getting mild infections transmitting is the fact that in those studies, people had high antibody titers, which means that they had what was necessary in the blood to protect them against that. So perhaps it's still possible that if you're vaccinated to pick up the virus, have a very mild or asymptomatic course of illness and transmit it. But so far, it looks like that's less likely to be the case. Another piece of real world data is from Israel, where more than 50% of the population was vaccinated. There was a dramatic fall in the cases and a dramatic fall in this number of severe cases, suggesting that not only do you prevent severe cases and deaths, but you probably are also reducing your ability to transmit the virus. So it seems like that is the case, that your ability to transmit is significantly reduced when you have the vaccine.
Okay. But I guess from your perspective, though, we want to still reinforce the notion that even after you get vaccinated, certainly during the uptake time, which is 3, 4, 5 weeks, several weeks, you need to continue the same practices in terms of masking, physical distancing, washing your hands, correct?
That's right. And there's two important reasons for that. For one, you may be one of the small group of people who didn't react well to the vaccine. And what I mean by that is that you haven't been immunized. That happens with all sorts of vaccinations. Some people simply, for whatever reason, do not form a response to the vaccine and are still susceptible. So you can still get COVID. And you don't know if you're one of those people. So therefore, you should be doing all the things that you should be doing anyway, masking, washing hands, all those things. The second reason is that there's a still sizable chunk of the population that hasn't been vaccinated yet. So it's still important to normalize the behavior of masking and keeping distance and washing hands and all those sorts of things. And in order to model good behavior for everyone, if people stop doing that, then that kind of behavior will start to ripple through the population, even among those who've never been vaccinated. So until the time where we're confident that cases have dropped significantly, and until the time we're confident that a significant number of people have been vaccinated, you won't likely hear any changes to those recommendations.
I'm curious, once, as many Canadians as possible are vaccinated, do you envision, will we go back to all of us wearing no masks?
One important thing that was observed among many things that was observed during this past winter season is that flu numbers were virtually zero. There were a few, but very, very few. The same thing was observed in other countries, in America, Australia, UK, many, many countries. There are many reasons why that could be the case. It could be the masking, it could be distancing, it could be reduction of people congregating, it could be the reduction in travel. But if we go back to masking is relatively simple, it's relatively cheap, and there's virtually no harms to the person who wears a mask. Not non-medical harms, at least. So even though COVID is likely to go away in terms of the volumes are likely to fall. We're never going to eradicate it, but it will fall. We still may make the argument that wearing masks will not only prevent COVID, but it will prevent flu. Every year, there are several thousands of Canadians who get flu, and some of them die. And even more, tens of thousands in the United States who get flu and die. So a very good argument can be made is, why not institute masking during the winter season to prevent flu plus other respiratory viruses? And that way you won't have the same problems we've been facing virtually for 100 years since the last flu pandemic, or since the last very large flu pandemic. So I would imagine that masking is going to be here to stay for a long time. Maybe not year round, but likely through the winter.
Certainly it's just not a practice in North America that we're used to, but because of the pandemic, it may be something that sticks around. And obviously there are wellness benefits, right? Health benefits to the population as a whole.
Exactly. You're protecting yourself, you're protecting others. It should be noted that masking before the pandemic is common in other countries, in East Asia, for example, and they also get flu seasons. So masking isn't the whole story. It's not going to be able to prevent all the cases, but if it has a substantial effect, such a low risk and cheap maneuver, it seems that that's likely going to be part of our living for a while.
Yeah. One thing I wanted to drill down a bit is because of the vaccine supply issues, we saw quite a bit of controversy over the gap between your first dose and second dose. Pfizer, for example, recommends 21 days. We had, I don't know, it was Ontario Health, Public Health, because of the supply issue and the need to get the second doses out to people, they were lengthening that gap to 28, 35, even 42 days. Any concerns from your perspective in terms of that much more of a lag time between your doses?
So if you want to be a purist with the evidence, we don't actually know the right answer. We don't have the purest evidence to tell us 42 is equivalent to 21 days, for example, if you prolonged it. But there's a lot of indirect evidence that has been used in people in the trials who did delay their vaccine to show that they had a good response. Plus, there's other in vitro data that's used to look at one dose to see how long people have antibody responses, and in the people who, not just in vitro, but real life data to show that people have prolonged, sustained antibody levels, even just with the one dose. So the second dose, of course, is recommended and important, but there is a pretty high degree of protection even with the first one. So we just have to deal with the realities of vaccine shortages. And even the WHO recognizes this. And the WHO made a recommendation that the Moderna vaccine, for example, the longest gap that is recommended is up to 42 days, where past that, the idea being that you may have to restart the vaccine series from the first dose. So it seems like, based on expert opinion, people who understand vaccinology, understand their immune response, that the lag it may be important, but can be safely done the lag can be safely extended out to 42 days.
Yeah, I think the controversy really was over the fact that it was not the manufacturer's recommended dose gap, but that's because that's what they tested for, 21 days. So they couldn't say with certainty beyond that, but vaccinology practice would suggest it's okay. I want to also, let's just deal with side effects for a second. I read recently that if you're allergic to, and tell me if I've got this right, polyethylene glycol, you should not take the mRNA vaccine. Do you have any other updates on allergic reactions to the vaccines?
So the number of allergic reactions based on the real world data, I think there was a paper published about 2 weeks ago or a week ago in JAMA. The real life anaphylaxis rates are extremely small, like less than 0.5%, very, very rare. Of course, people have side effects like the arm being stiff or painful, or people having some mild fever, some muscle cramping, that kind of thing. But in terms of anaphylaxis, like allergic reaction that may be life-threatening, those are virtually non-existent. They occur, but very rarely, which means that it's going to be safe for the vast majority of the population to take. Polyethylene glycol itself is actually a medication that can be taken. It's a laxative, an over-the-counter laxative that people can take. Very rare for people to have reactions to that laxative. Also, the drug or that chemical is actually found in other drugs as well, very commonly, even over-the-counter Tylenol. So people have reactions, but those are extremely rare. And that was supported by the real world evidence looking at the UK and the US in terms of anaphylaxis being extremely rare. There has been no additional side effects have been noted in the post-marketing surveillance. So nothing unexpected so far with reactions.
And in terms of, we should mention also in terms of safety, I understand there's now 6 vaccines in phase 3 trials or on the market. No reporting of hospitalizations or death is my understanding. Is that correct? Out of 75,000 participants in those 6 phase 3 trials?
That's right. So that is an amazing piece of data to think about how well you're protected against the virus using these vaccines. It's like really mind-boggling when you think about the accomplishments of the mRNA vaccine. This is a totally brand new vaccine in terms of marketing, in terms of being out there. It's been worked on for years, of course, but this is the first one that's actually been put out. How quickly it was designed. It took a while, of course, as usual, to study the drug, to do the proper regulation, the proper study. That was all very well done. But it's amazing to think how effective, how fortunate we are that how effective the vaccine is against the virus. And fortunately for Canada, these are the two vaccines that we have widely available that were first approved. So it's very promising data for Canada and the world.
I'm going to move on to our audience questions because we've had hundreds. But before we do, can I ask Alon, how are you and your colleagues doing? Because this has been pretty much 24/7, 7 days a week demands on you people. How are you guys doing?
Personally, I can't complain. Of course, I've worked hard as many people have, but there's other people who have worked so much harder than I have, working on the front line in the ICUs, on the general medical wards and the EDs. And no doubt there is a significant number of people who have experienced distress, anxiety as a result of looking after people. I think the message to the public is to recognize that the healthcare workers are a very resilient group of people, but there's only so much that they could take. And that pool of people who are available to look after your loved ones is eventually going to shrink. We're eventually going to have a very few people, relatively few number of people who have not experienced one of these bad outcomes. And unfortunately, even if they don't, it's still a huge stress for the people to look after them. So how have they been doing? I think overall, people have been very resilient and been able to tolerate the stress. But the important message, I think, is that the more waves we have, the more stress that those individuals are under, the harder it's going to be. So there is that, we talked about the roller coaster earlier. The sooner we stop that roller coaster, the sooner we can kind of replenish the tank for all of these very, very hardworking frontline nurses, doctors, pharmacists, physiotherapists, a whole variety of frontline staff who work EVS, housekeeping, all these people who have done an amazing job throughout the last 12 months.
Well put. And I think further impetus to trying to get as many people across the province and the country vaccinated as possible. Exactly. All right. Audience questions, as I said, we've had hundreds. I just want to preface before we get into them, please understand we're going to get to as many as we can in the time allotted. So Dr. Vaisman, first question, in your ideal scenario for public health, what does spring, summer look like in Toronto? Will we be eating in restaurants in 2021 in the city?
The ideal would be no restrictions, but I doubt that that'll be the case. Given the pace of vaccination, I do think that things like masking, distancing will still be recommended, and also restrictions of large gatherings will probably be restricted. I think the summer, in an ideal scenario, this coming summer will be very similar to last summer, where we had very few cases in July and August. Many things were opened up. Patios were opened up, for example. People can do all sorts of activities in the outdoors. But as for the indoor stuff, reasonably speaking, like if I had to make an honest guess, I don't think that will be open quite so soon, perhaps in late summer, perhaps closer to August. It's just that the vaccination uptake has to be that much quicker for that to happen. So maybe a little bit more restrictions in May and June, and maybe a little bit more loose in later in July and August.
In the meantime, support your local restaurant with Takeout. Okay, Flavia writes, in Italy, there have been strong recommendations that anyone over the age of 55 should not take the AstraZeneca vaccine. Any reason that you know of, and do you think that we will be able to have a choice here in Canada as to the type of vaccine?
So the AstraZeneca vaccine has not been approved in Canada at this time, and whether or not you'll have a choice, probably the accurate question is about whether Public Health Canada will recommend for that group. In general, vaccines, for example, the flu vaccine, we have a variety of them. Generally speaking, the patients don't make a choice about which kind they want, although sometimes they can. What's generally the approach is that the right vaccine is given to the right group of people. So vaccines that have been shown to be effective in babies, for example, are given to babies, whereas the flu vaccines proven to be effective in elderly people or more effective in elderly people are given to elderly. So it's not so much, even if we have a variety of flu vaccines, it's not so much an individual chooses so much as the right vaccine is given to the right population. The reason there's an age cutoff that has been used by some countries in Europe is because in the AstraZeneca trial, there were relatively few people in the older age group who were studied. So it's not so much that we don't know that it's ineffective in old people, it just simply wasn't studied as well in that age group. And hence why in France and Germany, and they have made restrictions about who should get, or in Italy as well, about that age group. So that is where that 55, and some countries have used 65 as their cutoff simply because they weren't studied in the trial.
Okay, so that's a good clarification, actually. Thank you. How safe is it to order takeout? If someone coughs into their hands and then makes your food, can the virus then be transferred onto your food? How is it different from someone who coughs into their hands, touches a doorknob, then you touch the doorknob and put your hand in your mouth?
Yeah, it's an interesting question. For a variety of reasons, that hasn't been identified as a common source of transmission. But if somebody, suppose we have an example with takeout, which is generally safe, things you could do to try to mitigate the risk if, say, somebody coughed on your food. First of all, you can heat the food. Second of all, you should wash your hands before you eat the food. Third of all, you can refrigerate the food or freeze it. Some foods can be frozen and eaten later. In general, I don't think that's a major concern. I think I myself have gotten takeout throughout the pandemic, especially in the summer. I didn't do anything to the food. I simply washed my hands before I touched the food and washed my hands afterwards and ate the food. I don't think it's a very major concern. I don't think it's a very likely way that you'll transmit the virus to you.
Estrella, are there any residual effects of COVID? And if so, is there any way of minimizing them?
Yeah, so in a variety of age groups, there's been many studies looking at the residual effects. Some people have been experiencing chronic cough. Some people experience chronic fatigue, chronic muscle pains. There are some side effects related to viral illnesses in general that affect the heart. People have chronic failure of the heart, which is not common, associated with COVID and other viruses. Unfortunately, there isn't a way of minimizing them as far as we know now. There isn't a specific treatment such that if you get COVID, to prevent those long-term consequences from occurring. The best way to prevent them is simply not to get COVID. So all those measures that we've been talking about for a year now. So right now that there's ongoing study about that, but so far nothing can be done to avoid getting those side effects. There, of course, are symptomatic treatments like pain medication for people who have pain, but outside of that, there isn't a measure that can be taken to prevent them altogether.
Which vaccine is most effective and has the least negative reactions in the elderly?
So currently it looks like the mRNA vaccines are likely the most side effects. They appear to be causing many reactions in people. Again, it's not life-threatening reactions, that's quite rare, or allergic reactions, that's quite rare. It's more of the short-term 24 to 48 hour side effects like muscle pain, a little bit of fever, severe fatigue. That's probably going to be the same in elderly people, just like it is in young people. So compared to the other vaccines, and again, only the Pfizer and Moderna have been approved in Canada, compared to those, it seems to be more common. In terms of efficacy, we kind of alluded to the fact that the AstraZeneca may be less, we don't know for certain, but maybe less effective in elderly. The Pfizer and Moderna have proven to be quite effective. Again, if you look at the Israeli data where they targeted elderly people and vaccinated upwards of close to 90% of the population who is elderly, they have seen a very dramatic drop in cases among that group. So it appears that the Pfizer, which was predominantly used, the Pfizer vaccine is very effective against elderly. The other vaccines, we just don't have the data yet in the real world to say.
I have a follow-up for you, Dr. Vaisman. With regard to the side effects when you do experience, I understand we're not supposed to take any kind of acetaminophen or painkiller to mask the side effects, because apparently that is a way that we know that the vaccine is working, correct?
The theoretical reason why you wouldn't take an anti-inflammatory or antipyretic, which means an anti-fever medication, may be that you're stunting the immune response. So your immune system is getting worked up to the vaccine, to the antigen, developing a response. There's a theoretical risk that if you stunt that, if you blunt that reaction, you will have less immunity to the COVID. However, what that really means is that you don't need to take prophylactic pain medication. So if you know your vaccines today, you don't need to take Tylenol or Advil or any other medication, knowing that you're going to get a vaccine, knowing that you may have side effects. If you get the vaccine and you happen to have severe side effects, you could take those medications. If you have a severe pain, you could take a little bit of Tylenol to help you. You could choose not to. The pain is likely to resolve again in 24 or 48 hours. As well, if you have some symptoms that overlap with COVID itself, you should just go get tested for COVID. Like if you have shortness of breath, that's not likely to be a COVID vaccine side effect. That's likely to be COVID itself, or more likely. So it's just important to recognize there's a difference between vaccine side effects and COVID itself. But the bottom line is you don't need to take medications prophylactically, and you could take a little bit if you have severe side effects.
Okay, and I should say also, when in doubt, please consult your local or your family physician.
Yes, excellent point.
Why is Canada so far behind other countries in getting the vaccine? Why can't we produce it here?
Yeah, that's the million-dollar question for our federal government and our provincial government as well, about why we don't have the facilities here. It all boils down to what was the situation pre-pandemic. What was Canada making? What was other countries making? We just didn't have the facilities. For whatever reason, the pandemic planning wasn't in place to think about this being an important aspect of fighting a pandemic. I don't know why, or whether, what the political reason is. Needless to say that in America, there is a lot of investment in R&D, and they have the actual capacity to develop vaccines. A lot of countries much smaller than Canada make vaccines too, even if they weren't developed there, like Belgium, for example, a country that is far smaller than Canada in population and in area. They have factories that make vaccines. We just don't have we don't have the factories that make these kinds of vaccines very quickly. I don't know specifically why, but that is the main reason why we're so far behind.
Right. Next question. I'm 77 and have been doing my own groceries. With the new COVID strain, does that mean I should be getting groceries delivered?
It's a good question. I think the bottom line is that if you wear the appropriate PPE and you keep the appropriate precautions, your risk of getting COVID still remains low, even with the variants being more common. However, some people have different risk thresholds, especially if you're elderly. You may decide that even though case numbers are falling with the variants being more common, that this is the kind of the line for you to draw, that you're not going to do that anymore. You're going to get the groceries delivered. But for the most part, again, it's still low. I'd say if you're able to maintain precautions, if you're able to maintain masking, washing hands, keeping distance, you're unlikely to pick up COVID in those settings. If something has changed, you're not able to maintain those practices, then that would be a good reason to switch over to deliveries.
Right. Can people with autoimmune disease take the vaccine? If so, which one?
So whenever you're thinking about whether somebody can take a vaccine, there's two distinct topics to think about. One, is it going to work? And secondly, is it safe for me? The question about is it safe for people with autoimmune diseases, currently there's no reason to believe that it's not safe. We think that it is safe for people to take, for example, the mRNA, the Pfizer Moderna vaccines in people who have autoimmune diseases. Even though we don't have specific data, a large data set on people with autoimmune, there's no reason to believe that it isn't safe. The second question is that, is it going to be effective? There's some reason to believe that it'd probably be less effective than your average person who's not on immune suppressants. But we don't know to what extent. There's probably a spectrum, and everyone with autoimmune diseases is very different. Some people have very, very significant immune suppression. They're taking a variety of medications that are very powerful. Some people are not taking any medication. Likely in that group, the vaccine is going to be no different than a person who doesn't have an autoimmune disease. So there's a whole spectrum within that group. But the bottom line is that in Canada, the federal bodies and provincial bodies do recommend those people get vaccinated. Having an autoimmune disease is not a contraindication of vaccinated. Those people should go ahead and in fact are prioritized to get vaccinated.
All right, from Mark, how far away are we from being able to use at-home rapid tests in Ontario?
That's a great question. The Premier of Ontario made an announcement approximately 2 weeks ago about having a large supply and making them more readily available for some settings. The areas that are going to be prioritized are going to be workplaces and long-term care facilities or congregate care settings. Those are the areas where probably rapid tests are going to be most available. If you wanted a rapid test, you could purchase one online. You could get one shipped to you from America, for example. There's nothing stopping you from doing that. Will that be made available broadly by the provincial government, let's say for free for you to take home? It seems that that's not on the horizon in the next few weeks. That first it's going to be used in these other settings before it's going to be made available at home. Furthermore, with cases dropping, that's even makes it even less likely that's going to be made available for home from the province. But again, if you wanted to purchase one, you can go ahead and purchase one. There's lots of them online.
Another question from Mark, is COVID, we skipped over one. All right. Next one, what remains the greatest barriers to herd immunity?
So the herd immunity concept is essentially that if you vaccinate a certain proportion of people in your population, or they become immune due to spread of the disease, you will reach a point where the virus or the pathogen will eventually go away because enough people are immune, they're not going to be able to transmit the virus effectively. So with some diseases, that's going to be 80%, some it might be 70%, 90%, depends on how effective the virus is at being passed between people. With COVID, the only viable option to herd immunity is vaccination. Letting the COVID rip through the population is fairly clearly not ethical because it'll result in many people dying, and people who don't die are going to have lots of other consequences, as we just talked about. So essentially the question to various barriers to herd immunity is, what's the barriers to vaccination? The barriers to vaccination right now, the biggest one is supply, is just getting supply. The next barrier will be convincing people who are reluctant to get vaccinated, as well as not being able to vaccinate, let's say, some people who cannot be safely vaccinated. At this point, that group is very, very, very small. As I said, the people with severe reactions, allergic reactions to components of the vaccine, which is very rare. But there may be some group, perhaps in the future, that can't be vaccinated. They will obviously be a barrier to herd immunity, which is precisely why more people getting vaccinated is better, because we want to protect the people who cannot either not mount a good response to the vaccine or who can't get vaccinated.
And that ideal percentage of people getting vaccinated is what?
The estimations by the experts looks like somewhere between 70, 80%. 80% has been floated around very commonly. We never had that, of course, so we don't really know for sure, but that has been modeled as a rough estimation.
Okay. What are the top online resources for public reference regarding vaccine efficacy and safety and the vaccine distribution plan in Ontario? Thank you. I'm guessing first, UHN has a very robust website and a landing page dedicated to COVID, as well as the Ontario government.
Absolutely. Absolutely. So there's 4 levels you can look at. You could look very locally at UHN, and as you mentioned, we have the resources here. You can look at Toronto Public Health. They also have resources that are very reliable. Ontario Health, which is the body that has been covering COVID and all the public health measures, they are an excellent resources as well. So Ontario Health has a centralized repository of information regarding COVID and one of the subsections about vaccination. The Public Health Agency of Canada is the federal body that is looking after guidelines and approvals for vaccines. They have excellent resources that are public facing, that are geared towards patients to read and understand the efficacy and safety of vaccines. So Public Health Agency of Canada, or PHAC, is the site you want to look for.
And uhn.ca if you want to go to UHN. From Mark, is COVID destined to become an endemic virus, just like the flu or HIV, which we will have to learn to live with by periodic vaccinations and other public health measures?
Yeah, it seemed like the experts in the area agree that it's likely COVID will become common and not be eradicated. And for not in Canada, for example, that we're going to have to live with COVID. That is the most likely outcome in the next few years. So there are many other coronaviruses that circulate in the population that cause the common cold. If after some time we are able to vaccinate a significant number of people, and if the virus continues to mutate, there may be a time where COVID becomes as innocuous as a common cold. That would be very far ahead in the future. But regardless, COVID is not likely to go away completely. And as for whether we'll need to get recurrently vaccinated, only time will tell whether that's the case. It seems, based on the data from reinfections, that people can get reinfected within 6 months, for example, that's likely going to be the case. We're going to have to vaccinate maybe once a year, maybe twice a year. Only time will tell how often that'll be.
Right. From Eva, dentists practice in a relatively high-risk environment. Why are they not being prioritized in the vaccine rollout?
That's a good question. I don't know. I can't say for certain where dentists stand in the rollout of the province, whether they're phase A or phase B. I would imagine they were in the first part, but I can't say for certain. But I agree they they perform relatively high risk procedures that generate aerosols in the mouth that they can be exposed to. So I can't say for certain where they are in the vaccine rollout, but I agree they should be fairly high on the prioritization.
From Merrill, if and when we get vaccinated, will we be given a card or document certifying that we have had both doses?
That's a good question. So healthcare workers who've been vaccinated will tell you that you get, the Ontario Health has developed a centralized database of tracking who's been vaccinated, first dose, second dose. You will get information about the vaccine, and you will get a slip identifying or providing information about the vaccine you received, when you got it, when the next dose is, and all of that. So there will be written communication, a written documentation that you got the vaccine, and there's also electronic database to make sure that they're keeping track of everyone getting the vaccine in order to keep track of everyone in Ontario so that we know who has got vaccinated.
Next question. What is your view on KN95 versus N95 masks? I see many medical professionals using KN95. If they are recommended, where should you buy them to ensure you are getting a quality product?
So in terms of the masks that we wear in hospital settings, we wear a variety of surgical and procedural masks. We don't tend to wear KN95 masks, but what you can think of a KN95 is just a very effective surgical or medical mask. So it's very thick. It can it'll protect you against high velocity sprays, which doesn't apply to most people except for healthcare workers. And it's just as effective as any mask a healthcare worker would wear in terms of surgical procedure masks. The difference between that and an N95 mask is that N95 respirators, they are fitted to your face. There are a variety of models, and you have to get fitted. So healthcare workers, we all get fitted to the right mask size so that we can have a tight seal around our face. KN95s are not fitted to your face, so there isn't the tight seal that you get with N95. Do they provide a high degree of protection? Probably they do. But if one was performing an aerosol generating procedure, you would need an N95. So for the average person who doesn't do that, a K95 is just as good as a good procedure mask, for example.
And are these available commercially, like in a drugstore?
Yep.
Or?
Yep, you can buy K95s. They're available in stores. You can order them online. But again, it's just as effective as any, say, level 3 surgical or procedural mask.
From Linda, I live in a condo in which we are all seniors, with most in their 80s and 90s, and even one that is over 100. Wow, congratulations. Most of us have various health problems. Is it possible to get our vaccine shots here, since this is essentially an old folks' home that does not draw on government resources? I imagine they'd be considered early phase 2 then, correct? Or even late phase 1?
Yes, I imagine they'd fall into one of those two groups depending on the setting. Some of these areas, they're a little less clear. For example, retirement homes or congregate settings that are targeted during this phase, but depending on the situation in this individual's home, they may not be grouped under that. But as for whether they can be vaccinated on site, I don't know, but my understanding is that the public health units are looking at a variety of options to vaccinate people, recognizing that elderly individuals have less ability to come to a clinic and probably would benefit from people coming to them instead. So I can't speak to this person's situation specifically, but all options are being looked at. The goal is to vaccinate everyone as fast as possible. So if that means going on site or having mobile units, perhaps, I hope that's being done, that's being looked at in the city.
Absolutely. I mean, and we know we have that precedent with a lot of folks in long-term care where they had mobile units going to them. So as you say, they're looking at everything, every possibility. Next question. Being both mRNA, what are the basic differences between Pfizer and Moderna other than the storage requirement, i.e. what chemical biological characteristics differentiate the two in safety, duration of immunity, and particularly in adverse reactions? Will we have a choice, and how will pharmacies store?
Yeah, in terms of the duration of immunity, we don't know the answer to that yet. We think that both have very durable effect. The adverse reactions, it seems like Moderna may have slightly more reaction, but again, neither of them have long-term consequences. And both of them, the reactions, they'll last more than 24, 48 hours in most people. The biochemical or the characteristics, there isn't much difference between them outside of that. There is certain compounds that are found in the vaccine that modifies whether or not you need to keep them at a low temperature or at a very low temperature. So that's probably the main difference in the two vaccines. Whether you'll have a choice or not depends more about the practicalities of delivering them. So because Pfizer is less portable, generally speaking, than Moderna, where you get vaccinated will probably dictate which one you get. If you're getting vaccinated by a mobile unit, for example, coming to your long-term care, your seniors living facility, you're probably more likely to get Moderna. That's what's been used far more commonly in that population. Let's say you're coming to a hospital, let's say a centralized vaccination site at a hospital, you're probably going to get, or more likely to get, Pfizer in that case. Also, if the supply is better for one or the other, that'll also dictate which one you get.
And maybe a quick note, Dr. Vaisman, I understand that we should all be prepared when we do go. There's at least a 15-minute retention period where we have to stay in case there are any noticeable side effects.
That's right. So when you think about anaphylaxis, allergic reactions, the most likely time when that'll occur is in the first hour, and within that, the first 15 minutes. So as with some other vaccines, you'll be required to wait in the clinic for a short period of time, 15 minutes, to make sure you're not having any allergic reactions, and then you'll be free to go.
Great. Next question. Are hospital ICUs still over capacity? We were hearing a lot about the scary situation in hospitals in January. How are things now?
So things are clearly much better. There was a plateauing of ICU cases up until a few weeks ago, but now there's a steady decline in the cases. It's still quite high. The term capacity is an interesting one because ICU is so essential, hospitals have made modifications to try to adapt more areas to accommodate ICU patients. So you can stretch the capacity even more. You can use non-traditional parts of the hospital, like areas where surgeries are done, or like the post-operative care unit. Some hospitals had to do that or made plans to do that. So you can inflate the numbers or make it look better than it is. But the reality is that hospitals are the burden was extremely high on hospitals to look after patients with COVID in the ICU. But there are clearly improvements now. The overall number of cases in the ICU has steadily, very slowly declined, although very high still right now. Plus the number of cases in the wards, medical wards, has pretty significantly fallen.
Yes. Next question from Arlene. If you have the second dose of the vaccine, do you have to quarantine after flying?
That's at this point in Canada, the answer is yes. In America, the CDC has already gone ahead and said that anyone who has had 2 doses of the vaccine will never need to quarantine as a result of an exposure. So they feel confident that the vaccine is highly effective and you're very unlikely to pick up COVID, hence why you don't need to isolate if you've been exposed. The same recommendation has not been made yet in Canada. It's possible that it will be in the near future, especially when a lot more Canadians are going to be vaccinated. It's possible that that'll be the case. So not yet, but maybe soon.
Next question. Can you comment on the development of therapeutics which may mitigate the severity of the disease and reduce the rate of mortality? Some of those being developed right here at UHN.
Yeah, there's 3 drugs that have been found to have a mortality benefit or improvement in symptoms or duration of hospitalization or ICU care for COVID. The 3 drugs are named dexamethasone, which is a steroid that's been used for many years. The second is called remdesivir. It's an antiviral medication that has been repurposed for COVID and was originally developed for different purposes. And the third is called tocilizumab. It's a monoclonal antibody. It's it's a biologic, which is kind of like a special molecule that has been developed to attack a certain part of the body or certain reactive part of the body. The goal being to minimize your inflammatory response. Part of the problem with COVID is not only is the virus attacking you, but you're having a very significant reaction. So some medications like the dexamethasone and tocilizumab, their role is to suppress that overwhelming immune response. And those are the 3 that have been shown to be effective for the treatment of COVID.
Okay, I'm sorry, but we are reaching the top of the hour, and that means the end of our time. To all of you out there, thank you for joining us. Thank you for your questions. We really appreciate it. And thank you to Dr. Alon Vaisman, UHN infection control physician. We really appreciate you taking the time to be with us and take time out of your busy day to give us your insights and expertise. So thanks, Dr. Vaisman.
Thank you.
As always, this live stream will be on the Foundation YouTube page. For anyone interested in donating supplies or support items for our frontline workers, you can email covidsupport@uhn.ca. So COVID support is all one word, @uhn.ca. And someone at the Foundation will be glad to help you out. And finally, donor support. It plays a critical role in the research that we've talked about in some ways here today in terms of reducing COVID symptoms. It also helps our people on the front lines who are caring for treating the COVID patients. And the donor dollars fuel the research initiatives that hundreds of our Team UHN are working on right now. So if you're able to give, we ask you to consider making a donation. You go to www.tgwhf, that's tgwhf.ca/help. Thanks for tuning in. We'll be back in a month's time with another episode. Keep an eye on your emails, your inbox. In the meantime, keep practicing physical distancing, wash your hands often, and mask up. Stay safe, everyone.